Hi, everyone. It's me again, Nina Sanford from UT Southwestern Dallas, Texas, obviously in my office right now. So today I'm going to talk about rectal cancer. I think in the last decade or so, there have been so many advancements in the management of rectal cancer, which is great, but can also be confusing. So I guess in the next 10, maybe 15 minutes, I'm going to try to really distill all the data, all the new studies into a framework that we can use when we think about how to care for patients with rectal cancer. So let's go ahead and get started. Okay, so this is rectal cancer 101. So let's start with how we diagnose rectal cancer. And I break up into pathology, imaging, and labs. So pathology, this is usually done from a biopsy during colonoscopy. If the patient hasn't had one, you also want to get a complete colonoscopy to rule out second tumor. But what do you want to know from pathology? You obviously want to know the histology. Most of these, 95% or so, are adenocarcinomas. If they are squamous cell cancers, then you actually treat like an anal cancer. So everything else today is going to be for adenocarcinoma. For all tumors, you want to know mismatch repair status. And then for stage 4 only, you want to get these additional markers, KRAS, NRAS, HER2, and BRAF to determine systemic therapy. That's from pathology. Now, what about imaging? The most important imaging is a baseline high resolution rectal MRI, and that really helps with surgical planning. But you need to also know specific things for the MRI. It can't just be sort of any MRI. It sort of has to be ideally a rectal protocol. And what are the key imaging features you want to know? The first is the distance to the anal verge, which is the bottom of the anal canal, and the anal rectal junction, which is obviously where the anus and rectum meet, and also sphincter involvement, because that will give you a sense of whether the patient's a candidate for an LAR, sphincter sparing surgery, or need an APR, or something sort of in between, like a coloanal anastomosis. Second, you want to know superiorly the relationship to the peritoneal reflection, because generally tumors above that are treated as colon cancers, below are rectal cancers. You want to know the tumor length, the cradiocaudal length, and the thickness. You want to know if there's EMVI, because that is a risk factor for both local and distal recurrence. That is basically tumor invading into the small vessels near the tumor. You want to know the distance to the mesorectal fascia, because that determines whether or not the patient is at risk for positive margin with a total mesorectal excision. Then also you want to know if there are nodes involved and if there are tumor deposits and whether those are in the mesorectum or out of the mesorectum. The latter is harder to remove with surgery. In addition to the MRI, you want to get a CT chest and abdominal imaging, either a CT or an MR. And also PET is not indicated as baseline staging for rectal cancer. The most common tumor marker for colorectal cancer is a CA, so you want to get a baseline CA. So that's diagnosis. All right, let's jump into management. I'm going to start with locally advanced rectal cancer. These are all mismatch repair proficient tumors. So technically, all T3 node positive is termed locally advanced, but really this comprises a really wide spectrum. You can have like a T4 tumor involving the whole rectum or a small T3 involving just the upper rectum. So it's really a wide spectrum. For the purposes of this presentation, I'm going to break it down to low versus high risk, but obviously it's not binary, and we need to be a little bit more nuanced when we're thinking about treatment options for our patients. So let's start with low risk. That's this slide. So I'm going to divide it if you are intending organ preservation or not. So starting at the top, if the purpose is not organ preservation, the patient's getting surgery, there are really two options in my mind, and the majority of these patients do not need radiation. They only need one local treatment, and that is surgery, because they're going to get surgery. So the first option is to go straight to surgery, nothing preoperative, nothing neoadjuvant. If you look at the box on the right that says ASTRO and ESMO, those are actually guidelines by our professional societies showing which patients may be eligible for upfront surgery. For me, I will consider upfront surgery if it's an upper rectal tumor, they're an LAR candidate, they're T3A or B, that means that corresponds to the depth of invasion past the muscularis propria. If they're N0, the tumor is not encroaching the mesorectal fascia and there's no EMVI. What I really like about upfront surgery is that you can actually de-escalate the chemotherapy pending the pathologic findings. So maybe 3 versus 6 months of chemotherapy, maybe not as much oxaliplatin, et cetera. What is the data for upfront surgery? So this is not based on randomized data, but it's actually based on several prospective series, look in the box below, showing that the risk of local recurrence is quite low, less than 5% if you do upfront surgery. So that's the first option, upfront surgery. The second is upfront chemotherapy, and that is based on the prospect trial. So on these slides, the studies that I think are important are going to be in red. So I would consider the prospect regimen if they have all the low risk features above, but potentially if they're node positive as well. Otherwise, I really do like the upfront surgery option a little bit more because the option to de-escalate chemotherapy. It's important to know what the prospect criteria are. They had to be T2N1 or T3N0N1. The nodes had to be less than a centimeter, and they had to be LAR candidates. So what is a prospect regimen? It means that they start with chemotherapy on the study of 6 cycles of FOLFOX. Then you assess for response. Technically on the trial, it's more than 20%, but really the majority of these patients are going to respond. Only 9% did not. And then you go to surgery without any radiation and you get adjuvant chemotherapy. So that's sort of the second option if the intent is surgery. The prospect study was not done with an organ preservation option. So looking at the bottom, if they're low risk, but if organ preservation is intended, for whatever reason, the patient doesn't want surgery, they would need an APR, then the best evidence or the regimen of the best evidence is long course chemoradiation. I'll talk a little bit more about this later. 50 to 50.4 gray in 25 to 28 fractions with radiosensitizing chemotherapy, then FOLFOX, and then response assessment. And there's more on this in a later slide in this talk. So this is lower risk locally advanced rectal cancer. All right, what about the upper end of the spectrum? This is higher risk locally advanced rectal cancer. So let's first talk about what high risk features are. So looking at that picture here, I divide them into the risk factors for local recurrence versus distant recurrence. And some are obviously both, so it's not that black and white. So what are risk factors for local recurrence? These are distal tumors requiring APR, if they have lateral pelvic nodes, if the tumor is encroaching the edge of the mesorectal fascia, and if they have T4 disease. Risk factors for distant recurrence would be more involved lymphadenopathy and N2 disease if they have EMBI, and also elevated CA. So for locally advanced higher risk rectal cancer, really the standard of care is total neoadjuvant therapy. And now the most commonly used regimen is long course chemoradiation, chemotherapy followed by response assessment. That regimen is based on the OPRA trial, which was a trial in organ preservation that showed that if you gave radiation first rather than chemotherapy first, the rate of complete response and organ preservation was higher. That being said, the oncologic outcomes between chemo or chemoradiation first are the same. I think if there's no intent for organ preservation, then chemotherapy first is reasonable. Also, if the patient has more distant recurrence factors, then I would also consider chemotherapy first. What is chemotherapy? So again, this is about 12 to 16 weeks of FOLFOX or CAPOX. And then in patients with very advanced disease, potentially younger patients, we do also use a triplet chemotherapy, FOLFIRINOX, and that's based on the PRODIGE 23 trial. So you might ask, we've talked a lot about long course chemoradiation. What about short course? Is that like dead? Do we no longer use it here? Just a reminder, that's 5 gray times 5 without chemotherapy. So what do I think about short course radiation? Well, it really did fall out of favor, at least in the US, with a Rapido trial showing a higher rate of local recurrence at 5 years. Also, there's limited data for short course in organ preservation. Data shows that there's equipoise between short and long course in the preoperative setting, but there's not data yet in organ preservation. So I wouldn't use it for organ preservation, but here are scenarios where I would consider short course radiation for. First of all, if a patient does not have features from the Rapido trial listed here, so I guess these would be sort of like medium risk patients. Also, if the patient is elderly, so there's actually data showing that for older, frail patients, if you have them come every day for 5 weeks, that does take quite a beating or detriment on their quality of life. So older patients, I tend to favor short course, particularly if the intent is preoperative. And then also if the patient has metastatic cancer and you're trying to consolidate, you're trying to address the tumor locally, I do prefer short course to minimize their time off systemic therapy. So this is my framework for locally advanced higher risk tumors. All right, we're about halfway done. Okay, moving on the other end, we're not talking about local advanced, we're talking about stage 1 tumors. And I kind of put these pictures in as fillers. Obviously, they don't have to do with rectal cancer, but I was in England this past weekend to give a talk. So the first picture, I was at Hampstead Heath in London. It was beautiful. The second one, I was with a colleague. Unfortunately, the beer there is like kind of lukewarm. And the third one is at my friend's house. I just love home with the home library. Anyway, sorry for that tangent. So let's talk about stage 1 cancers, because we do see these in clinic as well, which is good. A lot of these are screen detected. So the majority of these are cured by local therapy alone, and surgery is the standard of care local therapy. So let's start with the earliest. These are T1N0 tumors without high-risk features. So what are high-risk features? These are generally LVI, grade 3, poorly differentiated tumors, if they are into the 3rd level of the submucosa, SM3, or if they have a positive margin from this initial procedure. But for a T1N0, you can manage it with a transanal local excision or an endoscopic submucosal dissection. They do not need an oncologic surgery. Going a little bit more advanced, if you have a T2N0, meaning it's invading the muscularis, or a T1N0 with high-risk features, either on the initial biopsy, or they get a local excision and you find those high-risk features, the standard of care is a total mesorectal excision. You take out the mesorectum, you evaluate the nodes. That being said, if the patient does not want surgery, and that may be the case if they need a colostomy or if they are medically inoperable, then you can treat with definitive chemoradiation, long-course chemoradiation, and you wouldn't do additional chemotherapy then. So that is sort of an alternative local treatment option. All right, so now we have all ends of the spectrum. All right, I'm going to talk about other sort of key points that I've touched upon already, but just giving a little bit more detail. So let's talk a little bit more about organ preservation, non-operative management. So currently, I think that the study that has set the standard of care is the OPRA trial, which randomized patients to either starting with induction chemoradiation or chemotherapy. So that really has the most evidence. Long course chemoradiation followed by FOLFOX or CAPOX chemotherapy, or maybe FOLFIRINOX, which is assessed in the JANUS trial. So 2 major studies looking to see if we can improve upon the current OPRA regimen is the JANUS trial, which randomizes patients to FOLFIRINOX versus FOLFOX. And also this German trial comparing short versus long course radiation. That is actually finished accruing and hopefully will report out in the next couple of years. How do you assess these patients? So after completion of treatment, 6 to 8 weeks after, you want to do a DRE, a scope, and an MRI. And there are really 3 response categories. The one is first is a complete response, then they go into surveillance. If they have a partial or incomplete response, they go to surgery. And then there's this 3rd category called a near complete response. And these should really get close follow-up. We know that about half of them will achieve a complete response. How do you surveil these patients? So the most highest time of risk for local recurrence is in the first few years. So more than 90% will recur in the first couple years, and then almost all in the first 3 years. So this is how we follow them. And this is sort of work in progress. I think we'll know more about the optimal surveillance regimen as a role for ctDNA, all those things coming up. But technically, you want to do a scope or a DRE every 3 to 4 months for the first 2 years, then every 6 months for about 5 years. MRI every 6 months for 3 years. CA every 3 to 6 months for 2 years and every 6 months after. And then the rest body, CT chest abdomen, every 6 to 12 months. And you can kind of tailor that a little bit, I think, depending on how worried you are, if there's something you're following. All right, next section, limited M1. So if a patient has metastatic cancer, you start with chemotherapy, obviously. And what chemo do you choose? Generally, you choose either a doublet or a triplet, depending on their fitness level. You can add Avastin or an EGFR inhibitor, depending on their KRAS status. Also, there are some nuances depending on their bleeding risk and if they're going to go to surgery, et cetera. You do that for about 6 months. If they're responding and then amenable to local therapy, you want to address all the mets, either a suction pump, SBRT, and then local therapy to the primary tumor. If they're needing radiation, I tend to favor short course to minimize the time off chemotherapy. But if they still have extensive tumor, then you could do long course chemoradiation. Also, some folks feel that, especially if the patient is metastatic, there may be more of a reason to aim for non-operative management, though that's not really a standard of care. All right, last section here is mismatch repair deficient tumors. Again, pretty much everything I've said already is for mismatch repair proficient tumors. So if they have a locally advanced tumor, you start with immunotherapy. That's based on the MSKC dostarlimab trial. You generally start with a single agent PD-L1 drug, either Pembro or dostarlimab. 6 months duration seems to be the sweet spot. The majority will have a complete response. If they do not have a complete response, though, we switch to standard treatment with chemoradiation and chemotherapy. You should know that these patients do respond quite well to radiation. So you would do long course chemoradiation. If they're M1, you generally start with Pembro or a 2-drug IO regimen of Ipi-Nivo. All right, so last slide. This is going to be more radiation specific. So if you're not a rad onc, then you can zone out. But what you know about radiation planning. So you want to give contrast IV and PO. You can either do prone with a 3D plan or supine with IMRT. You want to make sure their bladder is full. In terms of dosing, there's long course chemorads or short course 5x5. I kind of already talked about the dosing. What do you need to know about the target volume? So the boost volume, which is only relevant for long course chemoradiation, is going to be the mesorectum and the gross nodes plus a margin. And what do you want to cover for the elective volume? That's the 45 gray for long course and then obviously the whole volume for short course. So the stations you always want to cover for a rectal case are the mesorectum, where you have perirectal nodes, presacral nodes, and also lateral nodes, internal iliac and obturator nodes. And there's a little bit of, some people may boost those areas if they're grossly involved. And then for specific cases, you want to cover these additional areas. So if it's a T4 tumor or there is obturator node involvement, you want to include the external iliac node because that's like the next area. You want to include the inguinal nodes if they're positive nodes there, or quote unquote extensive anal canal tumor involvement because anal canal drains through the inguinal nodes. And then there's this third area that's called the ischiorectal fossa. It's in the third picture here, which is that space just lateral to the rectum. And you want to include that, extend a little bit into that space, not be the whole space, if there's sort of extensive external anal sphincter involvement. So you look at the pictures at the bottom, it shows those nodal stations. Try to put some screenshots in there. OARs. So I took this out of a great review in Pro in 2022 that gives some OAR constraints. We also have the Timmerman tables as well, but here are some OARs for consideration. So that is it. I am always happy to take any feedback on these videos if there's anything that can be helpful or if anything that seems a little bit off or you don't agree with, please just email me. That's all I got. Thanks. Hope everyone has a great rest of the day, and that's it. All right. Thanks, everyone.